Good evening, everyone. I'm Dr. Abbas from medical team of Sun Pharma. It gives me great pleasure to extend to you all a very warm welcome on the behalf of Sun Pharma for today's webinar on PCNL and ureteroscopy. At Sun Pharma, we believe in connecting eminent faculties from around the world for exchanging their skills and experiences with each other, which in turn benefits the patient. Today's webinar is one of the such events. With this idea, I take this opportunity to welcome today's moderator, Dr. V.Chandra Mohan. Sir is a managing director, urologist, andrologist, and kidney transplant surgeon at Preeti Urology and Kidney Hospital, Hyderabad, India. He is also honorary secretary of Indian Medical Association Kukatpalli chapter. He is a postgraduate student and super specialty students from AIMS and prestigious institute PGI Chandigarh. He has received gold medal from Honorable Mr. Jyoti Garu for 2005 year DNB Urology. His focus is on pediatric RIRS, laparoscopy and supine PCNL. He has conducted international, national level live operative workshops on RIRS, mini-perc, ureteroplasty and laparoscopy. He is a course director for 6 months in endourology fellowship program at Preeti Urology and Kidney Hospital. He has demonstrated more than 40 live RIRS, PCNL and laparoscopic surgery in national and state conferences. He has published 10 national and international publications. Recently, he has published bilateral simultaneous RIRS for calculus anuria in 4 months male baby and supine percutaneous nephrolithotomy in 9-month infant in Elsevier Urology case report in December 2019 and September 2020 respectively. His paper is accepted for publication, Retrograde Intrarenal Surgery for Renal Stones in Children less than 5 years of age in Indian Journal of Urology 2020. He has presented a video on our techniques of retrograde intrarenal surgery in less than 5 years old child at 33rd annual EAU Congress in Denmark. With the short introduction, now I request Dr. Chandra Mohan to take the webinar forward. Over to you, sir.
Yeah. Good evening, everybody, and good morning on the other side of the countries. A warm welcome for all of you. Thank you, Abbas, for the nice introduction from Sun Pharma, and I appreciate Sun Pharma for taking a lead in these tough times, pandemic period, corona times, taking lead in conducting such academic webinars with world-renowned faculty. Today, we are having Dr. Ralph Clayman with us. There is no need of introduction. In the entire world, he is a well-known surgeon, but I must introduce him in detail so that we all remember the hard work the professor has done, especially in the research. Dr. Clayman is a world-renowned for his expertise in minimally invasive surgery for kidney stone disease, kidney cancer, and stricture of the ureter. I mention again stricture of the ureter, which is not common, which is difficult to treat in the era of 1990s, and is listed among the best doctors in America for urology. As you all know, the most competitive environment in the world scientifically is in USA. He is a graduate of Grinnell College and the University of California, San Diego School of Medicine. Following general surgery and urology training at the University of Minnesota, he spent 2 years at Southwestern Medical School in Dallas, pursuing his interest in renal cancer research. Even in 1990s, 85, renal cancer is at the very, very low level of understanding except nephrectomy. The kidney stone disease and minimally invasive urology also he has done his research. Subsequently, Dr. Clayman spent 17 years at Washington University School of Medicine in St. Louis, rising to the rank of Professor of Urology and Radiology, Director of the Midwest Stone Institute, and the inaugural coordinator of the Division of Minimally Invasive Surgery. That shows the commitment of entire life towards the research. Whereas in 1990, as you all know, after which he became very famous, Clayman and his associates performed the world first laparoscopic removal of a kidney for a tumor. Any first surgery needs lot of understanding of the instruments, technology, and three-dimensional orientation of what he is doing on the patient live is not an easy job. He has done, and that remained as the landmark surgery in the field of urology. As well, he has also done laparoscopic removal of kidney and ureter to treat the cancer. They also developed a cutting balloon catheter to treat obstruction of the ureter and performed pioneering work on percutaneous and endoscopic surgery for ureteral and kidney stones. As you all know, endoscopic surgery was evolving in 1985 and 1995 only it came into the, at least in Indian scenario, much of the surgeons have done. Before that only, Sir has done live surgeries in 1990s. He established the nation's first fellowship program in minimally invasive urology in 1984. Trainees of his program now occupy academic position at universities throughout the United States, Brazil, Spain, Italy, Canada, and Israel. I am surprised after the announcement of this program, most of the juniors called me, said that this is the most fortunate event in my life. I agree for that. Clayman is the author of textbooks on laparoscopy and percutaneous urological surgery and has published more than 400 peer-reviewed papers and book chapters. I have only 20 papers, which I am feeling very, very tough. 400 peer-reviewed papers is not a common thing. He is co-founder and co-editor of the Journal of Endourology and has 14 minimally invasive surgical instrumentation patients to his name. That shows the research again. Finding out a new instrument to do the surgery is not easy. He has received numerous national and international awards. In January 2002, he joined UC Irvine School of Medicine as chair and professor of the newly formed Department of Urology, taking challenge. During his 7 years as chair, the UC Irvine Medical Center Urology program came to be ranked among the top 20 programs in the country by US News and World Report. That's great. In 2009, Dr. Clayman stepped down as chair of urology only to become dean of the School of Medicine. After a successful again 5 years of dean, he elected to return to the Department of Urology as professor. He currently is fully immersed in his clinical and research work in kidney stones, ureteral and renal obstruction, and renal cancer, while enjoying the opportunity to work closely with resident fellows and students. I must say that you are one among the most renowned faculty with a lot of knowledge and research. We are fortunate today to know the complications related to the endoscopic surgery of the stone, percutaneous surgery, and ureteroscopy. With this introduction, I hand over to Professor Dr. Ralph Clayman. Thank you very much for giving this opportunity, sir.
Thank you very much, and thank you for that very, very kind and very thorough introduction. I am very appreciative. Let me share my screen here, and we'll get started. I hope everybody is well where you are and that people are staying safe in these very challenging times. I'm going to cover complications in ureteroscopy and in percutaneous stone removal, but I need to explain that a lot of this is going to be with regard to things that we're doing here and ways to avoid problems. I'm more interested in helping individuals to avoid a problem rather than have a problem. So let's just start here. If one looks at all the different complications that can occur with percutaneous stone removal, death still occurs in 0.03%. Fever is very common, but not necessarily indicative of an infection. Bleeding remains one of the major problems at close to 8%, and transfusions are still high at 6%, along with problems with renal perforation and either a hydro or hemothorax or pleural effusion, which really increases if you are going above the 12th rib. My comments today will relate in general to percutaneous stone removal done in the prone position, which is what we're doing here. There are certain things with regard to the complications from a preoperative, intraoperative, and postoperative standpoint, and we'll cover all those. Imaging is important because poor planning results in a poor result. Then the urine culture before you do a percutaneous procedure really needs to be documented as sterile, unless you have an absolutely normal urinalysis. I like to stress how important it is to look at the transverse coronal and sagittal views of the CT scan. Study this before you go into the operating room. You want to know the size of the stone in all three dimensions. If you just looked at the stone at the sagittal, you'd think this is a 2 by 1 centimeter stone. If you didn't look at the transverse, you would realize that, or fail to realize, that the stone is also 3 centimeters. This is a 2 by 1 by 3 centimeter stone, which is extremely large volume. And again, if you only looked at this, you might even think about ureteroscopy. But given this third dimension, this is not a stone good for ureteroscopy. We also always measure the stone to skin distance to see if it would possibly be amenable to S-wall. We also want to know what the Hounsfield units of the stone would be, because that's going to determine how we work with our laser. And then when you look at the sagittal and study the sagittal coming off of the vertebrae to see exactly where would we go. And in this patient, we're going to plan for an upper pole tract. We know this tract is going to be 8.9 centimeters. We know the pleura is a little bit above, so we want to come just over the 12th rib when we put this tract in. So when we go to the operating room, we know exactly the size of the stone, the hardness of the stone, the shape of the stone, and the amount or the length of needle that we're going to have to put into the patient in order to secure the nephrostomy tract. We also look at the angles of accessibility, and this is important to figure out, can I get to that stone with a rigid nephroscope or with a flexible? So if you look at this CT scan, if your nephrostomy tract comes in through the upper pole here, the angle to the stone in the lower pole would be 130 degrees. I know that I'll be able to get a rigid endoscope actually down into here. On the other hand, if I have a stone here too, that angle is 72 degrees. I know I'll be able to get my flexible nephroscope into there. However, I also know that I'm not going to be able to get my flexible nephroscope up into here. That angle of 52 degrees is too acute to allow me to do that. And so if I had a stone here, I'd already be thinking, well, this is the stone or part of the stone that I'm going to approach with a flexible ureteroscope from below. As far as prophylaxis goes, the AUA guidelines from 2013 recommend that you do give antibiotic prophylaxis around your percutaneous stone removal, and we certainly adhere to this. Even if the urine culture is sterile, we will still give antibiotics preoperatively and then intraoperatively, and usually at least one dose postoperatively. As far as intraoperative complications with percutaneous stone removal, there are 5 areas that I'd like to touch on. 1 is access, 2 is tract dilation, 3 is how we extract the stone, 4 is problems of hemorrhage, and 5 is what I call impending doom. So first and foremost, for access, know your anatomy. As soon as you start the case and put up a catheter from below, shoot a retrograde ureterogram so you know the location and distribution of the calyces at that point in time. Because what you see on the CT scan, which may be a month or more old, is not necessarily what you're going to see with the patient prone in the operating room. And this just shows that particular dilemma. This is a patient on the table that we're doing our retrograde ureterogram. We had a plan already made out for this patient. But then when we did the retrograde ureterogram, you'll see what we got. You'll see the guide wire goes up and around And as you fill this out, you realize that this is a ptotic kidney and it has fallen and twisted. So your anatomy is all thrown off. And you need to see this because this is what's going to be happening in real time. And this is your challenge in real time. If you did not do this, your preconception would mislead you and you would have a very difficult time with the case. So do the retrograde so you know your anatomy. Few problems of access. We are using a ureteral access sheath in all of our percutaneous stone patients for rapid entry and removal of the ureteroscope, and also for keeping the pressure in the kidney low. This really facilitates our cases. What happens if the access sheath won't pass, if the nephrostomy needle won't pass, and how do you secure a through and through guide wire? So this is us in one of our cases. We routinely start out with a 16 French access sheath, and we will pass this over an Amplat super stiff guide wire. We already have a 12 French Foley catheter in the bladder to drain the bladder throughout the procedure. If this doesn't pass easily, we stop and then take it out and see if the 14 French obturator will pass. If that passes, then we'll put up a 14 French. If that doesn't pass, we'll try a 10-12. And if that doesn't pass easily, then I'm just putting a stent in and we'll go and do this on another day. We've gotten very much into measuring things. It's taken me 40 years to realize how important it is to measure things. And so the needle, number one, you need to take a look at it. It has a notch, and that notch needs to fit into the base of the needle, or else the point is not properly exposed. So if this is up like this, there's no point to the needle. So you've got to make sure this is seated nicely in order for the needle point to come out. Secondly, you already know going in the OR how long the track's going to be because you measured that on the CT scan. That measurement, if anything, may overestimate the length that the needle has to go in to access the collecting system. But again, you're going to put this little marker here on the needle at precisely what you've measured on the CT scan. So I know in this patient, there's no reason for me to put the needle in deeper than 5 centimeters. If I haven't entered the collecting system at that point in time, I know the needle has missed the collecting system. Again, all of our patients have an access sheath up, and we're doing all of our percutaneous access under fluoroscope and endoscopic control. So we actually watch the needle come in the collecting system. Once we have the ureteroscope up and we can actually see the needle in the kidney, we'll then proceed to pass a guide wire through the ureteroscope and out through the needle. And that's what you're seeing here. Or maybe, So we're passing this, and what we want to do is pass that guide wire into the shaft of the needle. As you see it there, there's the needle, and there's a guide wire going in. And then you'll pass that out onto the flank. Before you remove the needle, though, before you remove this needle, you want to, again, take that same little plastic indicator that's on the needle and move it down. So now you know exactly how much needle it took to get into the kidney, and so you know the exact length of the tract. That's an important number because you'll use that number and transfer it to your balloon and to your access sheath. So if the ureteral access sheath won't pass, you want to downsize it. If the needle point seems dull, you want to reseat the needle, and you want to secure the guide wire and obtain a through and through access. Those are all key. In dilating the tract, what can go wrong is you can kink the guide wire or bend it. The balloon dilator may not pass, or the nephrostomy sheath may not pass. Those are all problems that you need to overcome. A bent guide wire needs to be exchanged. You can do that by passing a 5 French angiographic catheter over it, and then you take out the bent guide wire and put in a new guide wire, usually an Amplat super stiff. but never, ever, ever work over a bent guide wire. For the balloon dilator and the Amplat sheath, if they don't pass easily, again, we use a 5mm fascial incising needle in all of our patients to basically incise the fascia, and that will cut the fascia. So now you have a 15 French opening. In placing the sheath, we always do this with a forward twisting action. This is a video that Art Smith gave to me, but you can see this is all wrong. You're not going to be able to make this. You've got to follow the natural course of the wire. And if you don't, then you wind up with this. This is a wire that is now kinked. That will never, ever come out of that wire. And so you've got to pass your 5 French angiographic catheter over that. And so this is the 5 French angiographic catheter. It has a very nicely tapered tip. And you can pass that. It will actually, this catheter will actually go over the kink in your guide wire. And once it's over the kink in the guide wire, you can pull out the kink guide wire and then put in a new guide wire. And that's really what you want to do. And this is just a video showing that. So this is a kink. It will never come out. And all you want to do is pass this and it'll actually follow over. And now you can remove the old guide wire and put in a new guide wire and then pull out the 5 French and then continue. That's really key. Fascial incising needle, I've been using this for years. A lot of people don't even know about it, but once it gets passed over the guide wire, these blades will then incise the fascia, the lumbodorsal fascia, to 5mm, or if you want 10mm. We usually use the 5mm. This is very quick, it's very easy, and once you do this, your catheters and everything else pass easily. And this is just showing the fascial incising needle being used in this particular patient. And again, you just pass it in. The blades are always parallel to the ribs. I have not made a big enough skin incision, so it's a little bit hanging up at the skin. And then it goes in and you pass it all the way in and pull it all the way out. Now realize that's a 5cm shaft. If you have a patient where the tract is very, very short, so let's say your nephrostomy tract is only 6 centimeters, then you're just going to want to pass this needle in maybe 2 or 3 centimeters until you cut the fascia, but not all the way to the hub, because you certainly don't want to cut the kidney. What about dilation and dilation techniques? Amplatz dilators, Alkin dilators, and balloon dilators. I have to admit I'm a fan of the balloon dilator. This is a very nice study that was done in 2016 reviewing this, basically showing that the balloon will save you time, fluoroscopy time and OR time, and cause a slightly less drop in hemoglobin, although not statistically significant, and a lower transfusion rate, although not statistically significant. Stone-free rates are the same for all three. The problem with the balloon is that it costs more money, and obviously the Alkin dilators are the least expensive way to go. As far as the tract dilation, again, here's the nephrostomy needle. We've moved this little marker down right to the skin. With the ureteroscope, we've seen exactly where the needle enters the collecting system. So when I pull this needle out, the distance from this marker to the tip of the needle will be the true length of the tract. That is a very important thing to have, because I can then remember and transfer that measurement to my balloon dilator, but I can also take the sheath before I put it backloaded on the balloon, and with a knife I can pierce the sheath and create a very visible and palpable mark in the sheath that says to me, don't pass the sheath into the system any deeper than this. And that will prevent you from pass pointing and damaging the contralateral side of the kidney, or even worse, putting that sheath through the renal pelvis, causing extreme amount of extravasation. Prevention of sheath misplacement, then mark the sheath with the measured length of the tract, view the sheath coming into the system, and if you err, always err on the side of being too shallow with the sheath rather than too deep. If you're too shallow, you can dilate with a grasper or replace the balloon, inflate, and advance the sheath again. If you're too deep, then that's a perforation of the renal pelvis, and that's a big perforation. And at that, I would tell you, just put your nephrostomy tube in and come back at a later date. Do not proceed with the stone removal. This again is from Art Smith. Here, the sheath is too shallow, and you're seeing some bleeding as you're going through the parenchyma. Here's the guide wire. There's some perisinus fat here. And here he's using a grasping forceps to widen this in order to enter into the true renal pelvis. And there you see the stone. I prefer to replace the balloon and under vision, redilate. This is not as big a problem and not an indication to stop your procedure as the following, which is where you've passed the sheath too deep into the system. This is very problematic because now what you're seeing is bleeding and you're seeing fat on the other side. Then if you continue, you're going to be extravasating fluid into the retroperitoneum, or worse than that, if you've actually entered the peritoneum, then that fluid is going trans or intraperitoneal, and you may wind up with an abdominal compartment syndrome, which is a life-threatening situation. For stone extraction, you want to be aware of injuring the infundibulum, UPJ injury, and also stone remnants. How do you get to the inaccessible calyx? To prevent infundibular injury, again, look at your retrograde ureterogram and endoscopically look at what you're seeing, and don't try and put in a large scope through a narrowed infundibulum. Downsize your scope, even if you need to a short, rigid ureteroscope. UPJ injury occurs because you push too hard on the stone doing pneumatic lithotripsy or ultrasonic, and you actually rub the urothelium at the UPJ raw. Again, this is why I like laser lithotripsy. It's a much more, in my opinion, gentle way of breaking the stone up, and I think my control is better. For the inaccessible calyx, again, this is why it's nice to have an access sheath up, because you can put up your ureteroscope and access that easily. So for infundibular injury, we will place a nephrostomy tube, usually 24 French, across the infundibulum and leave that in place so it will heal alongside that the shaft of that larger nephrostomy tube. For UPJ injury, we'll put up a 714 endopilotomy stent and leave that usually for 3 to 4 weeks. The inaccessible calyx you can usually get to with the flexible ureteroscope. And that's what this is showing. And again, in this particular case, through this nephrostomy tract, the flexible scope, you can get it here and you can get it here, but you cannot have it make this kind of an acute bend into this calyx. This is inaccessible. But if you have an access sheath up, you can easily pass your flexible ureteroscope into this calyx, break the stone up with the laser, or grab a piece and pull it into the kidney, and then actually, as Mahesh Desai has described, basically then take it out with your flexible or rigid, and you're passing the ball. For a hemorrhage, again, the best way to deal with hemorrhage is to not have it. Before you do the patient, check for any bleeding diathesis, and if there is one, correct it. Know the meds the patient is taking, make sure they get stopped if they're platelet inhibitors. You can do the case under aspirin. However, as Art Smith has pointed out, you wind up with an increased transfusion rate of 19%. The other thing is, where do you put your needle? And this again is why I like the endoscopic perk, because we can guide the needle so it goes through the papilla or the fornix. We have evidence to show that the least vascular part of the kidney is the renal papilla. And then under endoscopic guidance, you can make sure the sheath is in the collecting system and not back in the parenchyma. If you do have hemorrhage and you can't control it, we use a K-tamponade balloon, or you can use a Counsel catheter to compress the bleeding vessel. We are injecting hemostatic agents at the end of our perks now to try to stop bleeding. But if all else fails, you need to do an angioembolization. This is the K catheter. It goes over a guide wire. You inflate the balloon right there. And this is what it looks like inflated. It goes up to approximately 40 French, and this will absolutely stop any bleeding from the tract right there and then. The other thing you can do is a counsel catheter. If you're going to do this with a counsel, make sure you cut an extra hole behind the balloon, because otherwise this infundibulum will be completely excluded. And this is just showing that inflated to stop bleeding. At the end of our cases, though, we are using Surgiflow. This is the Surgiflow applicator, and we will put it down the sheath as we're removing the sheath after we have pre-placed a 10 French Foley catheter and inflated the balloon to prevent any of the hemostatic agent from getting in the kidney. And that's what this is showing here. What you're seeing is we're sucking out the sheath, taking out any fluid from the sheath. We have a 10 French Foley catheter, and we've blown the balloon up where this enters the collecting system. And now we'll instill the Surgiflow as we pull back on the sheath, but we keep the balloon catheter in place. We'll cut the sheath off, and then we'll put compression on the flank for a full 10 minutes. Deflate the balloon. If there's no bleeding, take the balloon out. And if there's still no bleeding, then we take out the guide wire and we'll close the wound. So we're not leaving nephrostomy tracts or nephrostomy tubes, only indwelling stents at the end of our cases. And so this is just a 4x4 that's been cut. We'll put that over the balloon, put a little bit of pressure on that, and then clamp that at the skin level to create some compression. And I'll just leave that for a full 10 minutes by the clock. This has worked out very well for us, and I think has stopped our need to go to angioembolization in a lot of patients. The question now is, what happens if during your percutaneous removal, all hell breaks loose? And what I mean by impending doom is all of a sudden the patient becomes hypotensive. What's going on? And these are the four things that the anesthesiologist or you may notice. The anesthesiologist may notice there's difficulty in ventilating the patient. There may be blood clots in the drainage. If you see blood clots in your drainage, there's been a lot of bleeding going on. The patient may all of a sudden spike to fever, or the anesthesiologist may tell you that the pulse pressure is declining. Any one of these four things is very important to recognize, because when this is happening, it's a time to start thinking about getting out as soon as you can, because each one of these is a harbinger of a disaster. So this is where I would place a nephrostomy tube immediately and get out. The disaster diagnoses are four: a huge pleural effusion, acute hemorrhage, sepsis, or an abdominal compression syndrome because fluid is now filling transperitoneally. If you've got the pleural effusion, you can do fluoroscopy of the diaphragm in the OR or ultrasound. And if you see it, you can immediately place a 10 French Cope loop. This is going to be a huge effusion, and you can pass a nephrostomy needle. You're going to see fluid come back, pass a guide wire through that, take out the needle, and now immediately put in your Cope loop and drain it, and you're done with the pleural effusion, and stop. For acute hemorrhage, you're going to need to get blood in the room. For sepsis, you're going to be doing antibiotics, but again, you're quitting in both cases. And if you think the patient has an abdominal compression syndrome and they're prone, you want to turn them supine, and under abdominal ultrasound, you'll find a big pocket of fluid. Pass a nephrostomy needle, get some fluid back, put in a guide wire, take out the nephrostomy needle, put in a Cope loop, and immediately, acutely start to drain that fluid. I can't tell you how important that is. That will save your patient's life. Postoperatively, we worry about pleural effusions and pneumothorax, which is rare. Hemothorax, very, very, very rare. I don't think I have seen one of these in 4 decades. Hemorrhage, sepsis, and then the errant tract. So preoperative planning, again, precludes postoperative problems. Know your anatomy. Pulmonary effusions, if you're below the 12th rib, it's 1.4%. If you go above the 12th, it's going to happen in 15%. Do your punctures with in exhalation with the patient's breath held. Hemorrhage, we are now doing 24 French tracts, so they're a bit smaller. Is this helping? I can't tell you, but that's what we've done. We reduced our tract size, and we are using hemostatic agents, but I cannot tell you if that actually makes a difference because the incidence of severe bleeding like this is only about 1.4%, 1 to 2%. Sepsis, again, documented sterile preoperative urine. That's our modus operandi. And we do cultures of the stone and cultures of any renal pelvis urine at the time of the procedure, especially if the patient has hydronephrosis. Management, pulmonary problems. For a pleural effusion, put the cope loop in the post-anesthesia recovery room. Hemorrhage, angioembolization. SIRS, systemic inflammatory response syndrome to sepsis, antibiotics. And then the errant tract. For colon, you're going to reposition the tube, make it into a colostomy tube, put in a stent and a Foley. If you happen to hit the duodenum, which is rare, just pull the tube back into the kidney, put in an NG tube and bowel rest. For injuring a solid organ, just leave the tube in place and remove it usually 5 days later. So this is a huge pleural effusion. You place a 10 French cope loop in the recovery room, and then usually everything is drained. Then you can put it to water seal on post-op day 1, chest x-ray on post-op day 2. If there's no reaccumulation, you can pull the tube and send the patient home. Hemorrhage early, something like this where you see a blush, you're going to want to do an angioembolization and coil this. This is very effective. If you have a retroperitoneal hemorrhage, I would not try and drain this. I would just sit on it and wait it out. Patient's not going to be really comfortable, but trying to drain something like this is almost impossible. SIRS, the systemic inflammatory response syndrome, again defined by your temperature, heart rate, respiratory rate, and white count. If you take these 4 things and you have these plus hypotension, then you're into urosepsis. Realize that the midstream urine culture is not infallible, and a lot of these patients will have a positive stone culture of 35% or even a positive renal pelvis culture of 20%. The midstream urine is not predictive of whether you're going to get postoperative SIRS or not. But again, if you have a positive midstream urine culture, you're going to treat that patient until the next midstream urine culture is sterile. Increasing hydronephrosis is associated with higher incidence of upper tract urine infection. And if you have a history of an infected stone and hydronephrosis, your chance of urosepsis goes up 4-fold. Positive blood cultures, though, are rare. Now, here again, this is a colon injury. You're going to want to pull the tube back and place an indwelling ureteral stent and a Foley catheter for 2 days. I think that's the best way to go. This is a duodenal injury. You're going to pull the tube back till it's just inside the kidney and put in an NG tube and bowel rest for several days, and that will resolve on its own. You don't need to go to the OR for this. So in conclusion, for perks, sterile urine culture, study the CT scan, know your stone size, stone hardness, know the angles from the planned tract to the stone. For tract dilation, your super stiff guide wire, fascial incising needle, measure, and balloon dilation. And I stress the importance of measuring. Sheath placement, again, know how much sheath you're going to put in. Ureteroscopic monitoring will avoid a renal pelvis injury. For stone extraction, make sure your endoscope fits the infundibulum, no force, and we like to use the laser. Hemorrhage, K-tamponade or a counsel catheter, and have a low threshold for angioembolization. For postoperative problems, pulmonary, low threshold for placing a 10 French cope loop. Don't think that a small pleural effusion or a pleural effusion that's medium size is going to go away. In my experience, they don't go away. Hemorrhage is angioembolization. Sepsis, monitor for SIRS, check your stone and upper tract culture, antibiotic coverage. And the errant tract, if it's a hollow organ, you're going to basically divert the urine. If it's a solid organ, just leave the tube in place for 5 days, let the tract set up, and then pull the tube. So now we're just going to switch and go to ureteroscopy. In ureteroscopy, death also occurs, about 0.03%. Your biggest complication, though, has to do with inflammatory problems of fever, SIRS, or sepsis. Perirenal hematoma is rare. Stricture is rare. Splitting the urothelium depends on what you're doing. People have reported rates as high as 24% when passing an access sheath. That happens when you put too much force on the access sheath. Other problems of urine leak, ureteral obstruction, ureteral avulsion, almost unheard of unless you've basketed a stone that you can't release. Urinomas, stent symptoms, retained stones, renal colic, hematuria, and pyelonephritis, all definite problems. Why do patients die from ureteroscopy? Guido Justi put out a very important and very honest paper where they reported 6 deaths after ureteroscopy. 4 of the 6 were from septic shock. These patients did receive prophylactic antibiotics. None of them, though, had a preoperative urine culture confirmed as sterile. And the majority, or most, did not have a ureteral access sheath in place, which would then decompress the upper tracts. 1 patient died of hemorrhage. 1 patient died of cardiac arrest, which was also associated with sepsis. So let's look at preoperative preparation, intraoperative performance, and postoperative concerns. Again, you want recent imaging, you want to study your films, make sure you have a sterile urine culture. And we've been using tamsulosin to try to relax the ureter to facilitate the passage of our access sheath. We think this may be helpful, but we do not have a prospective randomized study to confirm it. In our retrospective study, we did find that the patients who got tamsulosin, we were able to place the ureteral access sheath in 88% of them versus only 34% who were unstinted and had no flow max. Recently, that rate of 88% is closer to 60%, but still, that's a 16 French ureteral access sheath. What about intraoperative performance? Let's look at these 6 areas. Again, endoscope selection. We're only using a rigid when we're in the lower urinary tract. Anything above the vessels is always with a flexible. My use of the rigid ureteroscope, to be honest with you, is largely limited to distal ureteral stones. Know your guide wires. The Benson, the Amplat's super stiff for passing the access sheath, but this wire, the nitinol guide wire, is the one for getting by an impacted ureteral stone. So if you know you have an impacted stone in the ureter or any stones in the ureter, the first wire up, in my opinion, should always be a nitinol guide wire. Your first pass is your best pass. So again, the nitinol gives you the best passage, ease of passage, but it's not as stiff as the Amplat super stiff, which is therefore what you want when you're going to pass up an access sheath. The Benson is, if everything is simple, that's a nice all-purpose wire. 2 catheters I would suggest to you to have in your operating room. One is a Cumpy catheter. It has an angled tip on it that has memory. And then if you want to pass 2 wires, either an introducer, 8 French, 10 French Amplat system, or a dual lumen. So this is the Cumpy catheter. This is a definite curve. It will not go away. It is a stable curve, if you will, and it allows you to direct a guide wire. So through this, you can pass a curved nitinol guide wire, and you can create any angle that you want in order to try to get around a stone. So in a case like this, if the guide wire is coiling here, you can pass the Cumpy catheter over the guide wire, and then you can twirl this in any direction and keep on sort of tapping to see at what point in time does your guide wire go by the stone. And as you twirl this around the stone, there'll be one area that when you advance the guide wire, it will go right by the stone, no force. Once it does that, then advance the Cumpy up into the kidney beyond the stone, and you can exchange the nitinol guide wire for an Amplat super stiff. If you're going to want to work with 2 guide wires instead of 1, you can use either the 810 Amplat system or the introducer or the dual lumen catheter. The only time I'm going to work with 2 guide wires is if I have an impacted stone in the ureter. I've gotten 1 guide wire beyond the stone, and I don't want to lose that. And now with the second guide wire, I'm going to use that to pass my access sheath, because I want to keep the guide wire that went beyond the stone in the system. And so this just again shows you that we've gotten 1 guide wire beyond the impacted stone. This one I don't want to lose. I passed up a second guide wire here. It's coiled underneath the stone, which is fine. I'm going to take out the 10 French, and now over this wire, I'll pass my Amplats, I'll pass my access sheath, and then I'll take this wire out. But this wire will stay in. I will clamp this to the drapes. This is my get out of jail free card. As far as false passage of the ureter, this is going to commonly occur when you have an impacted ureteral stone, usually at the distal ureter. The sign of this is the guide wire advances at first with some force. So you put force on it, and then all of a sudden it seems to go, but it's still a little more force than you're used to. And then when you look at it under fluoro, the tip of it is not coiling in the renal pelvis. That's a false pass. You need to recognize it when it occurs and not dilate over that. So if you do have that, you need to then leave that guide wire in place. Take your rigid ureteroscope at this point, because it's probably distal ureter, and look carefully at this guide wire, and then pass a second guide wire where this guide wire is not. The big mistake is to pull this guide wire out immediately. Then you've got 2 holes and you don't know which is the right hole to pass your guide wire up the ureter. So don't take that out until you've secured a guide wire in the true ureter. So I mentioned to you, we are using access sheaths in all of our cases. I can't tell you how important it is to use no force on this access sheath. Pass it slowly. If you meet resistance, downsize immediately. Take out the 16, see if the 14 obturator goes. That doesn't go easily. Take out the 14 and then see if a 12-10 will go. If that doesn't go, then just put up a stent and come back another day, because the stent will allow the ureter to dilate and you'll be able to put up an access sheath at that time. Don't force the ureter. It's very unforgiving. And again, as I showed before and mentioned before, this is just passing the access sheath up. And again, no force on that. 63 cases with a prospective randomized study with the access sheath from Glenn Premingers. This is old stuff, but it's still true. Decreased OR time, saved money on each case. No ureteral perforations in their series, but again, some people report perforations up to 24%. No strictures noted in either group. Other people have shown low intrapelvic pressure, which will decrease your pilovenous pilosinus backflow and decrease your chance of urosepsis. You get better deflection of the flexible ureteroscope because it passes up the access sheath straight, and your efficiency for stone clearance goes up, again, because of decreased OR time. This is from Olivier Traxer. This is a mucosal abrasion. This is splitting of the urothelium, and this is where you've split and you're all the way out through adventitia. They had 13% of their patients had this. This is due to only one thing, and that is excessive force on the access sheath, period. It is always my fault when this happens. When this does occur, we're going to put an indwelling stent for 2 to 3 weeks. The good news is it heals. Rigid endoscope, smaller is better. Again, as far as ureteral perforation, as you go down in the size of the rigid ureteroscope, your perforation rate also goes down. And we are only using the small rigid ureteroscopes now. We are not using balloon dilation, in essence, in any patients. If I can't get the access sheath up, I'm putting up a stent and I'll come back another day. What about instrumentation, guide wires, lasers, pneumatic probes, your stone baskets, your electrohydraulic lithotripsy probes? We are no longer using EHL. Avulsion or intussusception, risk is 0.3%. Again, this is only going to happen if you've got a stone in a metal stone basket and you pull too hard. We are not using any metal stone baskets. So no more wire stone baskets, metal stone baskets. They're all nitinol, if you will. And again, if I can't release the stone, I'll put up the 272 micron laser fiber alongside the stone and break the stone up. What is interesting is you can pass that fiber, it's so small, through the same port that your stone basket is, and it will go and you'll be able to break the stone up. You may fragment the basket too, but that's a fragmented basket that you can pull out is far better than an avulsed ureter. If you do avulse the ureter, that's a trip to the OR, an open case or laparoscopic. What about stents? If you don't leave a stent, in this case, these are incidents of ER visits among 161 ureteroscopy cases. Those who had a stent, 19% went to the ER. Those without a stent, only 14% went to the ER. But here's what happened in the ER. These patients who had a stent placed, they had a CT scan or they were readmitted, none of them required another procedure. These patients, however, 3/4 got a CT scan, half of them got readmitted, and 25% went to the OR to have a stent placed. Bottom line is, we're placing a stent in all of our post-ureteroscopy patients. That's what we're doing right now. What about if you place an access sheath? You should always then place a stent when you're done. A nice study by Manoj Manga showing that when they did not place a stent, the pain almost doubled. The need for medical assistant ER visits and hospital admissions went up 6-fold. So again, if you pass an access sheath, always then leave the patient with an indwelling stent. What about postoperative concerns of inflammation, Steinstrasse, and ureteral stricture? Again, the biggest thing after ureteroscopy is postoperative inflammation, and that's going to be seen in 6.8%. Fortunately, sepsis is distinctly rare at 0.7%, but that's what you're going to see. To avoid this, again, preoperative negative urine, or I actually like a preoperative sterile urine culture, perioperative antibiotics, and the ureteral access sheath, which will prevent pilovenous, pilosinus backflow. Postoperatively, antibiotics for only 24 hours. That's all you need. Longer course of antibiotics does not decrease the incidence of UTI, does not decrease the incidence of the need to be rehospitalized. If you have Steinstrasse there, that's a problem that you caused because you just didn't remove all the fragments. If you accept to break up the stone, I believe you also accept the responsibility of taking the time to remove the stone fragments. What's worse than a stone street, if you will, is what I call a stone wall. And that's where you have a ureteral perforation and you continue to break the stone up. And now you have pieces of stone in the wall. You can't get those out. They cling to the fat. And as a result, you may get a stone granuloma and a stricture. And that's a very difficult stricture to repair. Does passing of a ureteral access sheath cause a stricture? Well, the answer is no. Even if you have a full thickness split of the urothelium, in this series 12.5%, stents were left for a median of 16 days. The stricture rate, they only had one patient develop a stricture, 1.8%, which is really no different than the incidence of ureteral stricture after ureteroscopy in general. Again, looking at strictures in the ureteral access sheath in this study from the Crows from the Endourology Society, 2,000 cases. With a sheath, strictures 1.1%. Without a sheath, strictures 1.2%. No difference. So in conclusion, The best way to avoid complications is to not have them. Preoperatively for ureteroscopy, I would encourage you to make sure you have a sterile urine culture. Look at your imaging. It's good to have it no older than 4 weeks because stones move. We are giving all of our patients tamsulosin for a week prior to the procedure to help us get up the access sheath. Intraoperatively, most of our cases are flexible ureteroscopy. We use the nitinol guide wire because your first pass is your best pass. If I can't get around the stone, I'll use the Cumpy catheter. If that doesn't work, then I'll look in with the flexible ureteroscope and try and pass a guide wire under direct vision. Always work with a safety wire. If you're doing an impacted stone, get a wire beyond the stone and then keep that wire in place. Again, the ureteral access sheath and laser lithotripsy, I think, are very helpful. No more electrohydraulic lithotripsy, no more metal flat wire baskets or anything like that. And all of our patients get an indwelling stent at the end of the procedure. 3 things to remember: if it don't go easy, it don't go at all. Your first pass is your best pass. When in doubt, when you're in trouble, when things don't look right, put up a stent and get out and come back another day. Postoperatively, antibiotics for less than or equal to 24 hours, and then a stone culture. Again, always remember, no matter how bad the complication, it shall pass. It might pass like a kidney stone, but it will pass. Thank you.
Thank you very much, Dr. Clayman. You have almost addressed each clinical scenario with the literature support and some of the important points I feel is the length of the PCNL tract. One question from the audience that how accurate, because it's a 3-dimensional, how will you measure? Your needle entry point may differ sometimes. Can we really calculate the length accurately so that it can be predicted and performed in the operation theater the same, sir?
Yes. Okay. That's an excellent question. Usually what you measure in the sagittal view on the CT scan is longer than the actual tract. So if anything, it overestimates the length of the tract. And so you're actually quite correct. That's why I emphasize that once you do gain access, you pull the needle back under endoscopic control, pull the needle back to where you see it just coming in the collecting system, slide the little plastic marker down to the skin. Now, when you take the needle out, you measure that, and that is your true length. So it would overestimate. So it's not uncommon where we say, oh, the tract's going to be 8 centimeters, but the true length actually turns out to be maybe 6. So that's why, again, you measure at the time of surgery when you've passed that. So if anything, that sagittal view tends to overestimate the length of the needle that you need to pass. So if you pass it to that marker and you're not in the system, you're probably in too deep, not too shallow. Yes.
Yeah.
That's a good point. Thank you for asking that question.
The second question, before I share some of a few minutes my rare complication video, somebody is asking, do you recommend ureteral meatus dilatation before doing retrograde intrarenal surgery, especially in the era of 9 French access sheath and less than 9 French flexible scope?
Yeah, I have not.
Dilatation
Yeah. I haven't been dilating the distal ureter as a routine. I hardly ever will put up a balloon dilator because if the access sheath doesn't go up, and then you say, well, I'm going to balloon dilate this. Well, then the balloon goes up to like 15 atmospheres of pressure. You're definitely going to, yeah, you'll dilate the ureter, but you're definitely going to split it too.
Yeah.
We know we've developed a force sensor here, and we've done 200 patients. And we know at 6 newtons of force, that's where you start to split the ureter. So early on, what happens is that you get into this false sense of security. You start to pass the access sheath up, you meet resistance, and then you continue to put some pressure on it, just like you would trying to pass a Foley catheter past a external sphincter that's spasmodic. And you continue with a little bit of force gently, and all of a sudden it gives, like when passing a Foley, and you pass it up and you go, ah, that was great. At that point, you've split the ureter. So ureter does not give, it splits. And so as soon as you get resistance, back off, take out that access sheath. See if the 14 French will go. If the 14 goes, then you're going to put in a 14 access sheath. If that doesn't go, then we'll downsize to a 9, 5, 11, or a 10, 12. If that doesn't go, I just put up a stent and say, I'm coming back another day. Because I know with the stent, I'm going to be able to get up my access sheath. The access sheath just makes your life so much easier. There's just, we have a study where we looked at renal stones versus the size of the access sheath. So when we had a 16 or a 14 access sheath, our stone clearance rate was about 58 to 60%. When we only got up a 12 French access sheath, the stone clearance rate was 25%. Not worth it. Life's too short. Life is too short.
With your permission, I will share the 2 of the videos which I have. And
yes,
after that,
please.
we will take a couple of questions. Thank you very much for permitting. Thank you, Clayman sir, once again. I am showing related to the retrograde intrarenal surgery. Thank you, Clayman sir, once again, and Sun Pharma for giving this opportunity. This is one case where I want to show that.
Sorry, doctor. Your presentation is not visible properly.
Hello. One second.
Are we all right?
Yeah, are you all right now?
I can see your slide.
Yeah, I am muted.
No, you're audible, sir. You're audible. Please go ahead, sir.
If I'm audible, resound is not coming. This is an important case where I have done the mistake. When I have started using thulium fiber laser, I was excited that it is very faster. But sometimes we do mistakes without knowing the knowledge of what happens in the ureter. This is 37 years male patient who underwent multiple URSLs with laser, and whatever may be the laser, no conflicts of interest. Of course, in this case, I have used thulium fiber laser. That was a large stone. Many options will be there, like pushback PCNL or in situ URSL, pneumatic lithotripsy, access sheath with pneumatic lithotripsy, or laparoscopic ureterolithotomy or open ureterolithotomy. I have proceeded initially with pneumatic, but later on realized that it will take, it is moving up and down. I wanted to use the laser and do faster. That is my first mistake. I have taken precautions of passing a guide wire, but one important thing I missed is access sheath. I continued for a long time. That is my second mistake, nearly an hour. If you are staying with rigid ureteroscope and using laser, even if you are using low energy, low frequency, outflow will be very, very less unless you empty regularly, whereas in access sheath, continuous outflow will be there. At the end of the surgery, post-stent removal, patient developed high-grade fever with raised total leukocyte count. Now, when I went inside after antibiotic usage, I found a lot of flakes. Any urologist will understand that this is thermal damage. Normally, after routine ureteroscopic surgery for stone, you will never see like this. Then I realized that stent will not work for this patient as the entire ureter got damaged. And after some time of doing nephrostomy, then I have done nephrostogram. I could not get the entire ureter. In fact, there right at the level of the PUJ, obstruction is seen. Unfortunately, this was not there preoperatively. spindle-shaped strictures are formed in the ureter, then I realized that this is a very bad stricture. Almost entire length has gone. Subsequently, I have done Boyari flap right from the lower end to the upper end. It is only 1 minute video. There is nothing here to show it is a standard Boyari flap. Only thing is that do not produce such complication as Clayman sir said. Always be careful with ureter. Sometimes the PCNL bleeding is better than long stricture of the ureter. Then we mobilized the flap by marking like this. This is the long flap which came luckily. Otherwise, we planned the intestine, but this came and edges were bleeding. Then we tubularized that. Ultimately, this is the stricture area which is cut after the nephroscope is passed, identifying the most proximal part, almost PUJ. Now, proper interrupted anastomosis and then tension-free anastomosis is most important. Fortunately, this patient did. See, this is the last stitch. Now, this is the bladder and this is the movement of the ureter. It is able to move few centimeters up and down. That shows that it is not under traction. Now, post-op 1 year, he is doing well. Case 2 is entrapment of basket. Never estimate and underestimate the size of the stone in CT. You see here, the basket is strapped with encircled 2.2 French hook and it is not coming out. As Clayman sir said, I tried by the side of the basket. I went and broken the stone. Unfortunately, the 2 fringes of the basket has broken. I was afraid because if the small tip of the nitinol basket is broken, like this you see, I was doing is a large stone. We should not forget large stones only get trapped. Now I burnt with my laser fiber one of the fringes. Then after second time it has happened, then I stopped and did PCNL. My message is that PCNL is very, very important. They each complement. So one should be very, very acquainted with the PCNL procedure. Even in PCNL, I noticed one problem in this case, that is the basket is a compressed wire. When I am pulling the basket, it was not coming out. In fact, it is coming out long length. I realized that basket is getting unlooped. The main structure of the basket is getting unlooped like this. So unfortunately, I could pull it out completely. And most of the times it is not visible on X-ray. So you have to do antegrade as well as retrograde ureteroscopy to confirm that you are not leaving any foreign body. My third case is, don't think that RIRS does not cause bleeding. You watch this surgery at the infundibulum, at the infundibulum, at the infundibulum. Everything under vision is better, but sometimes see, suddenly respiratory movement is doing and you are getting bleeding after some time. This will be torrential bleeding sometimes because it's like knife. See here. See here. Immediately remove the access sheath. Otherwise, you will have a lot of problem. Even the clots in the bladder have to be evacuated. If you keep the access sheath and keep on washing with water, flexible scopy, lot of blood will be lost. Similarly, I had one more case where I have done this. The first case was my junior, my fellow, and the second case is while doing the upper pole bifid system, I was using high watt laser. I was in hurry. I used high energy, and when stone fragmentation is happening, suddenly it touched the infundibulum and I had bleeding from the access sheath. So in retrograde intrarenal surgery, don't think that the bleeding will not happen. All you need is take it out. Most of the times they may not require any treatment because 200 micron, 360 may not cause that much damage. Without teamwork, all this cannot be done. Thank you once again, Clayman sir, for giving this opportunity. And we will go back to the questions again. Thank you.
Thank you. Very, very interesting cases and important points. Very important points. We've done some studies with the thulium.
Yes,
in the kidney. We just finished a series actually in pig model. and you're quite correct. Without an access sheath, you know, and this hasn't been reported before, the temperatures can get extremely high and cause exactly what you saw. With the 16 French access sheath, you're right, as you said, the flow is so good that despite the same laser, the same settings, the temperature doesn't get up into the range of danger, like 46 degrees or something.
Yes, sir. Sir, one of the senior Indian surgeon, you know, Dr. S.K. Paul, sir, who is very experienced in PCNL surgery. He is considered as the father of in the modern PCNL surgery in and for all the youngsters like us. He asked a very important question. Do you recommend tamsulosin in PCNL or RIRS every surgery? And
We
if
are
so,
here.
how many
Here's the
days
problem.
before and how many
Yes.
days after?
Okay. So here's okay. Number one, we are giving tamsulosin to everybody. We're giving it usually for a week, but in honesty, you only need 5 days because that's the half-life is such that in 5 days they would be fine. But for us, it's just easier to say take it for a week. So we're giving it for a week. Having said that, I cannot say to you that this absolutely works. So right now, this is anecdote. This is personal experience. This is retrospective information, okay? There is one study out of Korea with a force sensor showing that the patients who got tamsulosin, they were able to put up their access sheath with less force. That looks promising. So again, suggesting that it is of benefit. Right now at our institution, we have a prospective randomized study with Flomax and Cialis together, Flomax alone, Cialis alone, or double placebo. We need to get 200 patients in the study. So far, we have only about 30 some odd patients. So I can't tell you, we don't have any results yet. But based on that anecdotal information, based on that one Korean study, I'm continuing to give all of our patients Flomax for a week before the procedure.
Okay. In continuation of the same question, some of the patients after access sheath usage for more than half an hour complain intense urge to pass urine and pain in the lower abdomen if you have done under general anesthesia for few hours. We feel that tamsulosin and oxybutynin helps a lot if you have given few hours before. What is your comment? Intense desire to pass urine.
Yeah, I have no, it's an interesting observation because we've always attributed everything to the stent. We blame everything on the stent. We are giving our patients a B&O suppository at the beginning of the case, belladonna and opiate suppository at the beginning. I don't know, but I think that's a perfectly reasonable thing to do. It always has made sense to me that to treat before you create the problem.
Yeah.
I compare this, it's the difference between American football and rugby. American football, we put pads on before we go out to hit other people. In rugby, you put pads on after because you're hurting so much. So it's the same thing here. Treat the patient before, if you know that that's a complication, and if they have the oxybutynin and a muscle relaxant on board, maybe their symptoms will be less. But again, the thing, what I always say, what I love about urology is we have so much ignorance. There's no end to the research we can do. So a prospective randomized study, things like that are so helpful for stuff like this and so important.
Yes, sir. Yes. SK Paul sir continued one more question. Even I got the doubt. You mentioned that while doing PCNL, you put an access sheet. Do you do this in all cases or some cases, especially when you are doing prone surgery, prone PCNL?
Yeah, I'm doing it in all my cases. So we do all of them.
Access sheath.
Every single one has an access sheath. Every single one. We do prone flexible cystoscopy. and we pass our guide wire up, and then we'll, the patient I showed you was prone, all of them. Now, the key thing when the patient's prone, if you're going to pass an access sheath, you have to remember you're starting from down low and going up and into and up this way. So when you're passing your access sheath over the guide wire, don't have the guide wire straight at you. You want that down towards the floor, so you're going from below and up. But that's what we're doing in everybody. Every single one of my patients has an access sheath.
I mean, does the ureteric catheter, does the
And
same job?
And it's alongside the 12 French Foley catheter, yes. So we have a 12 French Foley catheter in the bladder and the access sheath alongside.
Okay. Another question from Rauf, who is from Hyderabad, India. He asked, what are the type of hemostatic agents are you using in PCNL?
Yeah, we are using Surgiflow now. We had been using Flow Seal. We're not using fibrin glue. The reason for that is we found that when fibrin glue will set up in urine and just stay there, almost like a clot. We didn't find that same situation when we experimented with Flow Seal. But the Flow Seal is more expensive than Surgiflow, so we're using Surgiflow. That's what we're using. The biggest problem you get into is the incidence of severe hemorrhage after PCNL, depending on who you read, is 1% to 2%, where they need angioembolization. Well, in order to show that something is making a difference scientifically, you would need a prospective randomized study of 1,000 patients. No one's going to do that.
Last couple of years, not much spoken about hemostatic agents in PCNL, maybe because of mini-per, not much discussed topic.
Yes, and I agree with you. I think that the downsizing of the sheath has helped. Yeah. I think the mini perks have helped. Yes. And actually, I think Mahesh decided a nice study of a prospective randomized study showing, if you placed a deep suture, and close the hole up, that seemed to work as well as anything else. But again, these are small numbers. We're not looking at prospective randomization of 1,000 patients. So we continue to use the Surgiflow.
Yeah. One simple, silly question maybe, sometimes when bleeding is there, after removing the access sheath, if you put a Foley's catheter through access sheath, it appears that it produces some tamponade effect. Definitely it is not logical, but if you put a Foley's catheter as nephrostomy, sometimes clamp it decreases the bleeding. Does it have any relevance?
No, I think you're right. I mean, if I put a nephrostomy tube in and I'm getting blood out of the nephrostomy tube, I clamp the nephrostomy and let everything clot off in the kidney, because this is no different than renal trauma. It's just that I know where the trauma is and I know who caused it.
Yes. One more question from the audience. If access sheath is not able to pass 9 by 11.5 French in any form, will you try once direct without access sheath flexible ureteroscopy?
You can realize, but in that case, I need to know that I'm dealing with, let's say, a really small ureteral stone, something that is in the 5 to 7 millimeter size range, because all I'm going to be able to do is dust it, because grabbing stone fragments coming out and going back up and back and forth is going to take a lot of time and potentially be traumatic to the ureter.
Yes.
And so life is short. In those cases, I will just put a stent up and I'll tell the patient we're going to come back at a later date. When you come back, you put up the access sheath and it's much easier. So it all depends on your temperament as to how much time you want to spend, how much work you want to do. But it is much more difficult. So for me, my time is shorter than your time probably. And so I'm putting up a stent and coming back another day.
I personally, this is a question asked from audience. I honestly, as I'm doing more RIRS cases, my stenting rate has increased. Now I am afraid of any small trauma or friction to the ureter. Now it is 30% I stent, 70% I do with access sheath. Very rarely in children less than 1 year, I try without access sheath. I
Yeah,
feel
well, see, yeah.
access sheath is very important instrument. The
I think
question,
it, yeah, it protects
question
things. It
from the
really does.
audience, sorry. If this is a very important question, if you do avulsion, there are guidelines, but majority of the juniors think if you avulse the ureter, not to be seen, I have also not seen, what is the immediate step a junior who has not done many PCNLs, who does not have an ultrasound, he has suddenly seen a ureter through the inverted ureter through the penis. What should he do immediately?
So the first question is, do you have a guide wire up into the kidney? If there's a safety guide wire up, I have done this once. You can de-intussuscept the ureter.
Will it survive?
I have one case, and it
Great.
worked. One case.
Great.
That is not a series. That is the good Lord smiling on you, and you cannot expect that he or she is going to do anything good for you for the rest of the year.
Yeah.
One case. So, but if you do not have a guide wire up, then you're going to the operating room, because otherwise that's your one chance of reestablishing things. If you just say, I'm going to put a nephrostomy tube in, then what you're probably looking at eventually will be a total ileal ureter to save that kidney.
Yeah. Right.
Yeah.
One more. Yes.
Yeah, the thing is, if you're not using metal basket, that probably will never happen to you. If you're using a nitinol basket, the bottom line is, if you meet resistance, stop. Just stop.
Yeah.
Force will get you nowhere but trouble.
Yes. One more question from Dr. Purnanandam and Dr. S.K. Pal sir. Actually, both of them are very seniors. Dr. S.K. Pal sir used to tell, if you are very precise in your puncture, even if you do 30 French dilatation, very rarely you require angioembolization. We do agree. What is your criteria? Immediate postoperative period, a person who has hemoglobin 14, you are seeing some hematuria following PCNL, maybe a difficult surgery. What criteria of hemoglobin and other criteria you take for immediate angioembolization?
Yeah, if I have to transfuse the patient 2 units, we're off to embolization. Now realize most of these patients will drop their hematocrit after the procedure. So if your pre-op hemoglobin is let's say 14 or 40, which would be a hematocrit of 42, I'm not going to worry about much unless they drop well under 30. They've got that cushion. But if they're bleeding enough that and they are hemodynamically unstable such that I'm transfusing 2 units, at that point we go to angioembolization.
Okay.
Yeah, but I agree with Dr. Paul, and this is what our studies are showing. If you definitely hit the renal papilla or the fornix, your bleeding is going to be much less than if you've gone through an infundibulum. And I know Evangelos Liatzikos has a series where he's gone with a transinfundibular puncture, and in his hands, it's worked out well. All I know is that in our pig studies, it was clear that there was far more blood flow around the infundibulum than at the fornix, and the least amount of blood flow of all was right in the papilla.
Yeah.
We now have a study right now looking at, if you do put a tube through the renal papilla, what happens to it? Do you destroy it? Do you lose the function of that part of the kidney, of that lobe? And we don't have our data yet. It's actually in the process now of being collected, and the histology is being done. And hopefully that'll be presented at the AUA in Las Vegas, God willing, in September, when we can all hopefully
Yeah.
get together again safely without a mask.
In extension of this, what is your opinion when you are inserting access sheath in all cases, when you are good with flexible scope, why can't you do supine PCNL and see papilla only in all cases and then do surgery? What is your take
Sure.
on?
I think that's an excellent way to go. And I think the evolution of the supine PCNL is a wonderful thing. It's easier for the anesthesiologist. And, you know, I think that's a great way to go. We put most of my tubes do go through the upper pole of the kidney. That's a little more difficult to do supine. But if your primary goal is to put in a lower pole nephrostomy tract, or even the mid portion of the kidney, I think supine is great.
Yeah. One more question from Dr. Mohsin. Repeatedly asked question, but still controversial. Single step dilatation versus sequential dilatation.
Yeah. I love the balloon dilator.
And majority of the Indian population, I don't know, are not using balloon dilatation.
It's too expensive.
Can you elaborate a bit why you such a senior continuously using balloon dilatation? Why others are not able to use it?
It's too expensive.
Oh.
So we started out when I was at the University of Minnesota. That was the first time anyone wrote about using a balloon to dilate the nephrostomy tract. I did that with Kurt Amplatz. At that time, a 30 French balloon was almost impossible to get. And we got one balloon. We used that balloon in 30 cases. We re-sterilized it and repackaged it, and we used it in 30 cases. Why these are disposable, I don't know. But I do know that for most people around the globe, this is too expensive. And for them and everyone else, the Alkin dilators are a perfectly good way to go, but you just have to be careful and you're going to have a little more bleeding.
Do you use Alkin dilators?
I only use the balloon.
Only balloon.
That's all I use.
We wanted to see that video anyway. If time comes next, we will see the video because very less people in India uses balloon dilatation. And one more question, maybe in a couple of minutes, we will close the session as we are crossing the time. If any foreign body is by chance entrapped, like a tri-prong, if it is broken while doing PCNL, how will you remove it?
I try to remove any foreign body. The most common foreign body you have is the tip of the laser. Because it's made of glass, it breaks off and you go, oh, my laser tip is gone. You're never going to find it. It's transparent.
Difficult.
You know, and so I have not been able to remove that. And I've not seen any patient come back with a stone and the pathologist goes, oh, by the way, there was a glass fiber in there. No. The other things I worry about with potential for stone formation. So if I can see it, I will try to remove it.
Yeah.
If I can see it.
If it is laser fiber, okay. But sometimes I have seen once, if you are using tri-prong steel, it has a junction. If you forcibly pull, that junction breaks and stay back. Removal of that is very tricky because it is open tri-prong. It may injure and cause torrential tear and damage, bleeding in the parenchyma. Removing that in a parallel axis is difficult. I mean, sometimes it is alarming.
Yeah, I have not had that experience, but I can imagine that, especially if you get it in the wrong, if you can't twirl it around,
no. Turning it back is difficult. Dr. Abbas, I think we have spent an hour of time. If you permit, can we conclude? You want to give conclusion remarks, please?
Sure, sir. Sure. Thank you very much, sir. On the behalf of Urology Divisions of Sun Pharma, I thank Dr. V. Chandra Mohan for excellently moderating the session. Thank you very much, sir. I sincerely thank Professor Dr. Clayman for his excellent deliberation and very informative presentation. It is our honor to have you as a speaker for this webinar, sir. We will never forget your messages about ureteroscopy. If it doesn't go easy, it don't go at all. Your first pass is the best pass. And when in doubt, stand and get out. Thank you, sir, for those wisdom words. I am pleased to inform all the viewers that today's webinar is recorded and we will be available for and it will be available for your reference at esearch.in webcast session. In webcast section, you can also view previously recorded webinars in the webcast section. Webcast section. esearch.in is a knowledge portal launched in 2016 by Sun Pharma. Through eSearch, you can also access prestigious journals like Lux, the Prostate, BJU International, Neurology and Urodynamics, and International Journal of Urology. You can also access AUA Video Library 2018, which has been recently uploaded, as you can see on the screen. You can reach us for getting access to esearch.in and for any further information. Today, 360 viewers joined us from around the globe. I thank all the viewers for joining us and for their active participation. Thank you all. Stay safe, stay blessed. Thank you very much.